Hello everyone. Thank you very much for inviting me to participate in this symposium. My name is Jose Wheeler and I will briefly review the neurovascular manifestations of COVID-19. I have no disclosures for this presentation. My objectives can be summarized as follows: to review the neurovascular complications and the presumed stroke pathophysiology among hospitalized patients with COVID-19, to discuss the impact of COVID-19 on acute stroke codes, as well as other time-sensitive cerebrovascular emergencies, and finally, to highlight ongoing algorithms and controversies on thromboprophylaxis among patients with COVID-19 and stroke. The putative mechanisms underlying the diverse neurological consequences of COVID-19, not just those related to neurovascular compromise, can be categorized into two main groups: the non-immunological and the immunological. The non-immunological reflect the systemic multi-organ compromise with acute respiratory distress syndrome, the consequence of hypoxia and hypotension, sepsis, kidney compromise, cardiovascular compromise, etc., as well as the occurrence of a micro and macrovascular thrombosis reflecting the coagulopathy in patients with COVID-19. The immunological are further subdivided into those that reflect adaptive and maladaptive immunity. The maladaptive refers to the cytokine storm with elevation of a number of inflammatory markers. All of that can contribute to, for example, the encephalopathy that oftentimes is multifactorial. When neuropathological studies have been done in some of these patients, relatively speaking, there is a very limited amount of neuropathologic data in patients with SARS-CoV-2 infection. The main changes are confined to changes related to acute hypoxic ischemic injury, arteriolosclerosis with perivascular rarefaction, perivascular inflammation, and widespread hemorrhagic white matter lesions. Please note that I am referring to perivascular inflammation and not true vasculitis. Looking at strokes, strokes are mainly ischemic and can involve large or small vessels. Less commonly, these patients present with intracerebral hemorrhage, often related to the anticoagulation used in their management. Even less common, non-aneurysmal subarachnoid hemorrhage and cerebral venous sinus thrombosis have been reported. Exceptional cases have been associated with reversible cerebral vasoconstriction syndrome, often in relationship to the cytokine storm, as well as the posterior reversible encephalopathy syndrome or PRES. What we can say based on current data is that strokes are infrequent. Ischemic strokes are more frequent than hemorrhagic strokes, and those strokes are more common with severe illness in hospitalized patients in intensive care units compared to those patients affected with mild illness. One of the observations that have been consistent throughout the world was that at the peak of the pandemic, the number of stroke admissions decreased, the number of stroke IV thrombolysis and mechanical thrombectomies decreased, as well as the number of activation of emergency medical personnel for stroke codes. Of those patients who were admitted to hospital, an observation has taken place that the median NIH stroke score in these patients was higher than in prior reports. How is it that the number of stroke admissions diminished? Why was it that those observations became rather universal? Well, a number of plausible explanations have been posited. Number one, the fear of the population of acquiring COVID-19 if attending an emergency department or the doctor's office. The increased isolation due to lockdown periods may have also reduced the detection of stroke onset by family members. Furthermore, there has been an increased overall mortality that may not necessarily have reflected that those were related to COVID-19. And in some countries in Europe, particularly at the time of the peak of the pandemic, the EMS system was overwhelmed. So at the present time, based particularly in a number of case reports, stroke patients appear to have an increased risk of COVID-19. We know that older individuals, those with cardiovascular comorbidities, those with diabetes, those with chronic lung disease, those with asthma, those with depressed immunity, underlying malignancy, are at increased risk. About 3 to 6% of patients, depending on the series, and particularly among those with severe infections, are at risk of stroke. There is evidence of a higher rate of stroke in COVID-19 patients compared to an influenza cohort. There is a hypercoagulable state with an enhanced risk for thromboembolic complications. That hypercoagulability is different from a disseminated intravascular coagulation. In some instances, the presence of lupus anticoagulant and cardiolipin and other antiphospholipid antibodies has been observed. However, we know that there may be a transient acute phase reaction associated with viral infections, and in many instances there was no second studies, no repetitive studies in these patients. Viral-induced inflammation, the cytokine storm, endothelial dysfunction, capillary thrombosis, and myocardial involvement also may play an important role in the mechanism of strokes. And finally, we are quite aware that viral infections and other infections may cause arterial plaque instability. Of note, a large number of patients with ischemic strokes were categorized as ischemic strokes of undetermined etiology or cryptogenic, and that may be a reflection that during the hospitalization, certain ancillary tests commonly done in the evaluation of these patients were not obtained, such as transesophageal echocardiography. There have been some instances of brain edema that has been attributed, brain edema that has occurred earlier in the course of the disease and more severe, that has been attributed to acute respiratory distress syndrome associated hypercarbia. And obviously, because of the pandemic, a modification of the acute stroke protocols for the administration and monitoring of IV thrombolysis and mechanical thrombectomy and the follow-up had to take place. It's important to remember that SARS-CoV-2 acts upon two host cell receptors, the angiotensin converting enzyme 2 or ACE2 receptor and the transmembrane protease serine 2. Regarding the viral coagulopathy in severe COVID-19, it has been known for years or decades that viral infections cause a prothrombotic state that has been previously observed with SARS. The specific mechanisms are not fully understood, but among the thromboembolic complications, the predominant thromboembolic complications are venous thromboembolism and particularly pulmonary embolism. The cytokine storm plays an important role as well in conjunction with the coagulopathy associated with COVID. The COVID-associated coagulopathy, known as CAC, is distinct from DIC, and it is clear that the D-dimer levels correlate not only with disease severity but also in-hospital mortality. And many protocols of thromboprophylaxis are based in some institutions on the D-dimer. This is to illustrate again that by far the main thromboembolic complication in the critically ill, mechanically ventilated patient is venous thromboembolism, particularly pulmonary embolism. Myocardial injury plays an important role. Patients may have acute coronary syndrome, cardiac arrhythmias, including atrial fibrillation and torsades. And some of those may be related to medications that are known to prolong the QT interval, like azithromycin and hydroxychloroquine. As far as recommendations of continued use of ACE inhibitors and or ARBs, angiotensin receptor blockers, at the present time, these patients should continue with these medications. There is no reason why those medications should be discontinued. A subset of very severely ill patients may require ECMO, whether it's a veno-venous or a veno-arterial ECMO. And we know that these patients are at increased risk for intracranial hemorrhage, brain ischemia, and less common air embolism. Different protocols for thromboprophylaxis have been proposed. There is no consensus. We know, though, that stroke patients are at increased risk of venous thromboembolism, that the rates of deep vein thrombosis is approximately 50% in patients with acute ischemic stroke, particularly in the first 2 weeks, particularly in patients with compromised mobility, like hemiparetic strokes, and particularly those associated with atrial fibrillation. The use of heparins makes a lot of sense, is a long-standing anticoagulant, has antiviral properties, is an anti-inflammatory, offers cytoprotective effects, directly binds to the SARS-CoV-2 spike protein, blocking the viral entry into the cells. The caveat is that the recommendation has been to monitor anticoagulation with anti-10A assays, but the caveat should be that many of the COVID-19 seriously ill patients have high bilirubin levels and high triglyceride levels that may affect the anti-10A. So the thromboprophylaxis for these patients will require mechanical thromboprophylaxis with thigh-length IPC or pharmacological thromboprophylaxis with either subcutaneous low molecular weight heparin or unfractionated heparin, or in a longer term with oral 10A thrombolysis. The Cleveland Clinic favors the monitoring every 48 hours of hospitalized patients with COVID-19 of D-dimers, fibrinogen, prothrombin time, and INR, as well as APTT. If the APTT is prolonged, they recommend to evaluate for lupus anticoagulant and antiphospholipid antibodies. Their recommendation for venous thromboembolism prophylaxis is with low molecular weight heparins, for those in renal failure with unfractionated heparin, and for those with heparin-induced thrombocytopenia with fondaparinux, as long as the platelet count is greater than 5,000. In addition to monitor the D-dimer, they utilize point-of-care ultrasonography in order to approach these patients. However, at the present time, the optimal intensity of anticoagulation in patients with COVID-19 remains unknown, and among patients who are discharged from hospital after sustaining COVID-19 seriously ill, there is a recommendation for extended venous thromboembolic prophylaxis with either low molecular weight heparin or direct oral anticoagulants up to 1.5 months post-discharge. Thank you very much for the invitation, and I'll be happy to entertain any questions or comments. Once again, I appreciate your kind invitation.